Good afternoon and welcome to this latest webinar from the Pierce Cumbria School of Medicine Research Hub and CumbriaMed. My name is Professor Jonathan Weber and I'm one of the directors of the Research Hub together with my colleague, Professor Sophie Day. So the purpose of our webinars is to showcase research and clinical service from the new Pierce Cumbria School of Medicine based in Carlisle. PCSM is a partnership. It's an Imperial College medical school in close partnership with the University of Cumbria and with North Cumbria Integrated Care NHS Trust, NCIC. So together and with other NHS organizations in Cumbria. So the aim of the webinars is to bring some of the research, cutting edge research in popular areas from Imperial College, together with the people who are applying that research and clinical service here in Cumbria. So in this webinar, we're going to focus on cardiology and in particular therapeutics and the really new research around the ECG, the heart recording that many of you will know. It's a great pleasure to introduce Dr. Madhusudhan Varma. Madhu's a consultant interventional cardiologist from NCIC and caring for patients with heart conditions, but he also leads the outpatient care improvement services for the hospital and oversees the safe use of devices across the trust. So, Madhu, welcome and look forward to your presentation.
Thank you, Jonathan. Thank you for inviting me to talk on innovations in heart treatment, particularly focusing on Cumbria. Thank you for all the attendees for attending the webinar this afternoon. When we talk about innovations in cardiology, I'm looking at issues around early detection, improved diagnostics, less invasive treatments, innovative surgical techniques, advanced and novel therapies, including drugs, all leading to personalized medicine. All of this is aimed to enhance patient outcomes, quality of life, and patient experience. This should be underpinned by continuous research efforts. So I'm just going to cover all of them, particularly focusing on Cumbria. Now, let me start with a simple and a common medication called warfarin. VKA is vitamin K antagonist, which is warfarin, which has been around for more than 60 years. It's been used to treat conditions which include cardiology conditions, which include things like thrombus formation in the heart, valvular conditions, preventing risk of having stroke, heart attack, or death because of thrombus formation anywhere in the body, particularly so in lungs, legs, or heart. Now, even though it's been used for decades, it has got issues related to usage of the drug. We know it for decades, but we still use it because we didn't have any other medication for these dangerous conditions. The issues which we found with warfarin are things like interactions with other medications, interactions with food and anything that we take. It works in a very, very narrow therapeutic window, meaning that if the dosage is too high or too low, it has side effects and complications, either with bleeding or with thrombosis, which means it needs very, very close monitoring, and that is invasive monitoring. And patients would know that they have to go to GP practices many times to be able to take the blood down, to draw the blood, to be able to check the INR levels before warfarin dose can be readjusted to make sure it's in therapeutic window. All this causes a lot of inconvenience to patients because this is a lifelong check. It's not something that we check once and leave it. In spite of all this activity that patients go through, we know that many of the patients don't fall within the therapeutic window necessary to achieve the efficacy of the tablet, meaning to prevent events. And we also know that many patients, in spite of all of this, remain suboptimal, either on the overside or underside, leading to events. And we know that many patients come into hospital with events like strokes and bleeding in spite of being on warfarin. So we do need to change. We do need to change in spite of these medications being around for ages. So novel medications started to be utilized and they started to be trialed, and Cumbrian patients were also participating in some of those trials for the last 15 years, wherein new novel medications, which are acting at a different part of the thrombosis chain, have been trialed on patients on over a decade on multiple thousands of patients. And what we found with these medications, with the new novel therapy, is that it not only acts similar to warfarin in terms of efficacy, but it actually makes better results with reduction of stroke, better results with reduction of bleeding. But more importantly for patients, it doesn't need careful monitoring, needing to go to the GP, needing to take the blood down, needing to monitor, readjust the dose, or sometimes they need to be careful about what they eat, what they drink. So it was a significant benefit for patients in terms of the novel therapies being launched very recently. It proves that even for a common condition, even for a long-term medication, continuous innovation for many years makes a big difference for patients. So let's look at a rare condition. A rare condition like amyloidosis. Until recently, we used to think that it's very rare. It has no treatment because it's a problem with a molecule, how it's bent, which leads to accumulation of protein in the cardiac muscle, which leads to symptoms like heart failure, breathlessness. We used to think it's very rare, therefore it's very difficult to treat. We don't know how to treat, and patients used to think it's fatal, and many patients used to die. But the more we started to look into this, the more we realized it's not as rare as we thought. And since we found treatment for it and we started to utilize the treatment, we started to see benefit in terms of patients having less heart failure and patients not necessarily need to die because we don't have treatment. And Cumbrian patients started to see benefits because we started to have patients being treated on them as recently. It started only last year, and we started to see the benefits straight away. Now, very quickly, these sort of innovations are happening all across the heart situation, not just on the muscle side or on the medication side, but also electrical problems. Many patients present with palpitations, dizzy spells, loss of consciousness, and we used to have different type of monitoring until recently. Now we are utilizing very high-end technology like apps and monitors on sensors to be able to detect electrical abnormalities, which means patients are less inconvenienced whilst we know what exactly is happening much more quicker than before. If you come on to pipe problems, that is much more common in terms of heart disease. Many of the patients who come to our hospitals, many of the admissions in a 24-hour day are related to cardiac issues related to pipes. Even though the problems with the pipes take decades to form, from a normal artery to an artery where there is a buildup of material leading to complete cessation of blood flow, leading to heart attacks, strokes, or death, even though it happens over decades, we know that the final insult can well be minutes. And these final insult could well be because the blood markers like platelets, which are activated right at the end, which actually blocks up the blood flow, leading to severe chest pain, sweating, which patients recognize as the necessary need to come to hospital or even end up having a cardiac arrest. So a lot of energy and effort has been put into investigating the platelets. To cut things short, over last few decades, people have investigated how do we reduce the risk of these platelets blocking the blood supply? How do we reduce the stickiness of platelets? How do we restore flow? How do we prevent the heart attack? How do we delay the heart attack? Is where we investigated and put in a lot of energy to focus on. If you look at the platelets, every single area, every single chemical within the platelets has been investigated and looked at medications to make a difference, to reduce the stickiness, to reduce the event rate. Even though we found many medications which help that and reduce the risk of heart attacks and strokes and death, we also realized medications like clopidogrel, many patients are able to not respond as other patients could respond. We found them to be non-responders, even though we didn't know why some people are non-responders in a clear fashion. We found different ways of addressing this problem of clopidogrel non-resistance by utilizing other medications like ticagrelol. And we realized that by utilizing other medications to address this issue, we made significant progress in terms of reducing the event rate. And again, invention with trying to address the problems led to significant benefits in terms of patient population. Now let's look at how innovative technologies have helped, including Cumbrian patients. For some patients where the blockage has been long-term, here you look at the coronary tree where the blood circulation of the heart has been compromised with blockages. Some patients with multiple comorbidity, these blockages have been there for a long time. And when these patients present with symptoms like angina or heart attack, they go through MDTs where they were found that stents may not be the best option. They go through procedures like open heart surgery, wherein veins were taken out from the legs and bypassed with the open heart surgery, put down to the different parts of the artery where there are no blockages, bypassing the blocked sections. What we're trying to do now is to see there are some patients where we might as well open up the sections which have been blocked for a long time. With improvement in technology in recent times, including in Cumbria, we are finding patients where using technology like CT scan, putting cameras into the arteries, we are able to isolate the sections where the blockages are by looking at what makes the blockages block, looking at the chemical nature of the blockages, understanding how do we understand from an open section of the artery till the another open section, all the blockage, how do we quantify it? And then how do we find mechanisms to try to open the blockage section and try to restore flow? New techniques have been evolved, wherein new technologies allowed us to go through the past section, sometimes go through the arterial wall and reach the blocked section, go through the blocked section and come to the open section again and restoring flow using balloons and stents. By doing that, some patients are able to avoid open heart surgery. Open heart surgery is a very invasive step. It involves bypass machines. Sometimes it involves lung machines. It involves anesthetic risks, and it involves a lot of post-operative time to recover. Whereas stent procedures, by doing these complex procedures, means that patients mostly are discharged home the next day. That is significant improvement for patients. And these high complex procedures are being performed now in Cumbria, demonstrating benefit to them using innovative technology. Finally, if I look at research, for the last 10 to 12 years where we've been involved with cardiology in Cumbria, many patients have been recruited into studies right the way through, right from 2010 onwards, into multi-center studies wherein patients are recruited whilst new techniques, new methods, new investigations are being trialed in patients across the country. And our own patients in these studies have been recruited in, and they found the benefit of the studies before the studies have become guidelines. And we have been covered in national press and also regional press about how good we were in Cumbria, even in 2016, how we are as good as, say, Oxford and Leeds in terms of recruitment of patients, in terms of how we managed to identify patients, get them in, and try to make the best returns for the patients. And patients themselves found a lot of benefit in going through the studies. This was another newspaper article in 2017 from a patient who said that he was in the middle of a massive heart attack. His artery was blocked. He was in a life-threatening situation, real emergencies, but he felt like he was Lewis Hamilton in a Formula One pit crew because the team, the way they performed, how not only they saved the patient's life, but also recruited them to studies at the critical time, which down the road now from 2017 on, this is standard guidelines. So these are the things that research and innovation brings for patients right through the studies, but also at the end of the studies. So let me quickly look into the future. The future, I think, is about prevention. That's where I think we need to be moving into. Prevention in terms of diabetes and cardiovascular disease seems to be the way forward, because the main problem I see is undiagnosed diseases that we currently have. If you look at diabetes, undiagnosed diabetes, we estimate that it's beyond 1 million people in UK are undiagnosed. We think around more than 5 million people are living with pre-diabetes, again undiagnosed. And this problem, if it remains undiagnosed, is not something which is sitting there doing nothing. It costs a lot of money and it leads to events. we are talking about billions of pounds. And this risk, if unaddressed, leads to events. Even though these people come into hospital, we know that 1 in 10 of these people with undiagnosed diabetes end up with heart attack. They come in and we deal with the heart attack as quickly as we can. Patients go home in day 2 and we make a very good difference to the heart. But because they remain undiagnosed, they come in with further events in future. So I think we need to do something for this group of people where if we don't look at preventing them from having further events, even in spite of doing best efforts in fixing them, they keep coming back. So what can be done? One of the ideas we plan to do it in Cumbria is about diabetes undiagnosed areas. We learned from people with diabetes who had weight loss surgery, bariatric surgery, and we followed them up before and after at 6-month point. And we looked at patients who had diabetes before, they remained diabetic, versus people who had diabetes before, after bariatric surgery, the diabetes was in remission, meaning they have no diabetes. And we looked at these 2 groups of people, looking at the urine sample and look for diabetic metabolites, proteins, and group of proteins which are going differently between these group of people. We were interested to look at the variation between these. To cut things short, if, for example, we are able to pick this group of proteins from urine sample for patients who come to us with heart attack, currently they are undiagnosed diabetics with blood tests. If we took samples of urine and checked for diabetes, if we identified diabetes or pre-diabetes in this group of people and started to intervene, we might be able to prevent further events. Second time. Say, for example, if we took this further into community, this screening, and try to address the undiagnosed diabetes by intervening before something happens, then we may be able to prevent even the first event rather than the second event. I think that's where we want to focus on for the future in Cumbria. Thank you.
Madhu, thank you so much. It's an enormous pleasure to introduce Dr. Siong from Imperial College, from the National Heart and Lung Institute. Siong's a recognized authority on cardiac rhythms. He's going to talk to us, I think, today about reinterpretation of the ECG. The ECG is about 150 years old, first shown by Waller at what is now Imperial College, St. Mary's Hospital, Medical School, 150 years ago, but now new information coming out by looking at regular ECGs. Siong.
Thank you very much, Jonathan, and thanks for the invitation. It's a pleasure to be here today. So, as Jonathan mentioned, my task is to talk to you about how we can look at the ECG in different ways, and I'll talk you through some of the program of work I've been leading in Imperial. So this is the ECG. It's a recording of the heart signal, and as we've heard, it's been here for over 100 years. And we look at it every single day. About 1 billion ECGs are done yearly, and many of you will have had one done. Many of you will have a smartwatch that can record ECGs, so it's a very commonly used test. Now, I'm a cardiologist. I think I know how to look at ECG, so I always teach my students to have a system, look at the different parts of the ECG. So look at the P wave, the QRS, and the T wave, and have a system in your mind on how to interpret it. Now, that's helped us, but at the same time, simultaneously hindered us from having to see the full potential of the ECG. Now, we've heard a lot about AI. What AI does is AI has no respect for 100 years of human history or what we've learned in the last 100 years. AI will look at the signals in new and different ways that we have not thought about. It's not restricted to the P wave, QRS, and T waves. It will look at all forms of combinations of the waveform and come up with its own diagnosis and make up its own mind. And hence, we can use this method to reinterpret how we look at this very commonly used diagnostic test. Just a bit of a primer about what AI is, because I think it's useful to talk about these concepts. We sometimes talk about traditional programming, where the human types and writes a program. And the way that works is the human writes the rules for the program, and it feeds a lot of data and asks the program to sort out the data into answers. So you can say, look at the part of the ECG called the QRS complex. Is it more or less than 120 milliseconds? And then you get the answers. Machine learning and AI flips this on the head. It's not reliant on human-defined rules. So what the human knows and the limitation of human knowledge is not a factor here. In machine learning, you feed a lot of data in with the associated label and the answer. And the machine looks at all the answers and the data, and it comes up with new rules to associate the answers and the data. So what is different about machine learning is it comes up with new rules that the human might not be aware of, and therefore can surpass human ability in looking at the ECG. How do these things work in general? So I'll give you a very brief overview. So if you want to train a model, an AI model, to distinguish circles from crosses, the only thing the human has to do is to give the model lots of circles and say these are circles, and give it a lot of crosses and say these are crosses. And that's really all the human needs to do. The model will break down the image into different parts, and it will on its own work out that crosses consist of diagonal lines, horizontal lines, and vertical lines. But crosses only have diagonal lines. So we don't have to set the rules. After a while, the machine will learn that crosses look like these and circles look like this. And if you give it a cross in the future and it only spots diagonal lines, it will be able to tell us this is a cross and not a circle. And this is how it does. But the human only needs to label the data and feed it into the model, and the machine will learn the rest. So you can see this can be applied to ECGs. Instead of sorting out circles from crosses, you can feed ECGs that are right and left on the branch block. You can feed ECGs of people with normal or abnormal heart function. You can even feed ECGs with people with future events and those without future events. You can predict future adverse event from the ECG. And that's really what the program of work that we've been doing utilizes. It takes a lot of ECGs, it puts into these neural networks, and we train neural networks to make diagnoses and predictions from the ECG beyond what a human is capable of. So I'll just walk you through a few examples in the next 10 minutes or so to give you an idea of what is possible with this technology. One of the things we did was to take ECGs to train the model to predict mortality. I guess it's important to know whether someone is about to die or may die in the next 5 or 10 years. So we fed over 1 million ECGs into a model, and the label we gave it was the time between ECG and time of death. So the model will learn signatures of someone who's about to die and signatures on ECG of those who may live for many, many years. And we got the ECG, the model to output an individualized survival curve. So if I put my ECG in with a single ECG, it will give you a prediction of what your likelihood of being alive or dead over the next 10 years for every single ECG. So in this example, it's saying at 6 months, there's a 50% chance they will be dead. At 3 years, there's a 95% chance that person will be dead. So if it outputs an individualized mortality prediction for every single ECG. And here are 2 examples from the test set. Of course, they are picked, but these are from the test set that the model has not seen. You can see in this individual is predicted at 6 months they might die because they cross this line of being more likely to be dead than alive. And the actual time of death happens to be close to that, around 6 months. On this other curve, this patient died around 4 years and the prediction was relatively close. So the model is able to pick up signatures of imminent mortality or even longer term mortality from the ECG and guesstimate the time of death. So we had a lot of interest in this work when we published it a few months ago. Some relatively positive press coverage, superhuman AI. But for those of you who read the Daily Mail, you'll know their approach. They said UK hospitals set to use superhuman death calculator. They would tell you all when you're going to die. Would you want to know? Which was something not quite what we were going for. But really what we were planning to do it was not to use it to calculate time of death, but to use it as a measure to track health and disease. So here are 2 patients who have had lots and lots of ECGs over 15 years. Every single dot is a single ECG. And you can see over 15 years, the predictions of survival drop as you expect over time, up until the time they die here on the red line. But what's interesting is when they're admitted as an inpatient, the prediction drops and it recovers and it drops and recovers. So it can be used for remote monitoring, to track dynamic changes, to watch your patients with heart failure in the community, be able to give an early warning sign of deterioration. Now, if you take this model, you take 500,000 individuals and you run their prediction and split them based on quartiles of risk. You can see if you're in the top quarter of predicted risk, these individuals die a lot more over 20 years. So there's clear discriminative ability of the model to pick up the highest risk from the lowest risk individual. So we can tell someone whether they're at high risk or low risk of an event based on a single ECG. What's interesting is that even if you just restrict to normal ECG, so an ECG that myself or Madhu has looked at and said it's normal, there's still something in there that we're not calling as abnormal that the model is picking up. So it's still able to pick out the highest risk group, even in supposed normal ECGs, and identify those with the greatest risk over many years of dying. So the model is learning subtle signatures that we as humans are not able to see or have not considered high risk, and it's able to pick that out and risk stratify and find the highest risk individuals. Now, when we do AI models, it's very important to make sure that we externally validate that. And the meaning is that if you train a model directly on a London population and try and using Cumbria, it might not work because it was learning features unique to a London population. So you have to externally validate. So what we've done is to test in multiple situations. We trained in a US cohort, tested in 3 Brazilian cohorts, and also a UK cohort, and found that this model works quite well in picking up the highest individuals. So we're confident that this can be transportable anywhere, including Cumbria, and it will work out of the box for any type of individual. There's always concern with AI that they are biased, that they might not work in certain ethnic groups or in one or the other sex, but actually we were reassured to see that the performance was relatively equal across the major ethnic groups and the 2 sexes, so reassured by that. And if you compare using AI ECG to what we already have, so we have currently some methods to predict risk. So we use risk calculators, we look at their risk, their family history, their medical history, and we come up with a risk. If you take an AI model and compare it to what we have, it beats that, but it's additive. So it can enhance some of the existing risk scores that we have to look at patients' risk over many, many years. One of the problems with these AI models is they are inherently black boxes. It's hard to understand what specific features they're looking at, but we can use some post hoc analysis to try and understand what it's trying to pick up. And what we found is not surprising. It's telling us things like a broad QRS complex that we know is bad. If you get abnormal T waves or ST segments, it's also saying it's bad. But what it's doing is synthesizing all these subtle components into a reproducible number that I think humans don't do as well as machines do. Now, the starting point was the prediction of mortality. Of course, that's not the only thing we want to predict. We want to predict lots of other heart outcomes that we might be able to intervene on. So we have now a suite of models that can diagnose and predict future heart failure, future arrhythmias, heart block, atrial fibrillation. And having this information allows us to maybe treat patients differently going forwards. And if they have undiagnosed heart failure, you might do an echocardiogram, pick up the problem, start some medications early, and change the trajectory, preventing hospitalizations, maybe even leading to massive cost savings across the health service. We also have other models that predict non-cardiac outcomes like diabetes. We heard from Madhu that it's important to pick up diabetes, kidney disease. They have various levels of performance, but these models seem to pick up signatures of those conditions. So we've had a series of papers recently in the last few months. One is on valvular heart disease. We had a fellow come from China who brought 1 million ECGs with him, and we were able to train a model to pick up future valvular heart disease. So we can predict whether someone will have leaky valves in the aortic valve, tricuspid valve, or mitral valve. We've worked on diabetes, as I said, so it can risk stratify those at the greatest risk of diabetes in the next 15 years. There's something in there that's capturing diabetes risk. And again, those at the highest risk group may be given aggressive lifestyle modification advice, maybe even early treatments, early weight loss treatments. We can also predict future hypertension. Again, those at the highest risk group from a single ECG, we can maybe, again, early lifestyle treatment, early aggressive blood pressure modifications. All of those things are possible now with a single ECG that we humans would never have dreamt of doing by eye. Now, one of the problems with ECGs in the UK in general, and certainly with even London hospitals, is that we don't have digital ECGs. All the models I've shown relate to digital ECGs stored in the digital infrastructure. But many of the ECGs in the NHS look like this. So they are scanned, they're folded, they're scrumpled up pieces of paper. So the models need to be able to handle those. So Varma, a talented intercalated PhD student, has adapted the models to not just take electronic signals, but to take lots of noisy and poor quality ECGs with the same aim of trying to make these predictions. Without going into detail, these models using even the images and the rough quality pictures also seem to work. So it can pick up undiagnosed heart failure in this example with quite a good AUC curve, so 0.8, which is very good by most people's standards. And we can now use pictures and not just digital ECGs to look at a whole range of different outcomes like arrhythmias, heart failure, and so on and so forth. And here's what the model is looking at different bits of the ECG to make its prediction. A final bit, I mentioned at the start that we now have a lot of ECGs that can be recorded using wearable devices. There's now the opportunity to move this beyond the hospital. So if we could have someone have a smartwatch, record an ECG and make a prediction or make a diagnosis, that would really enhance the prevention piece that Madhu mentioned. We're moving away from hospital treatment towards the community, and there's the opportunity here to use wearables. One of the problems is wearable ECGs have a unique noise signature not present in normal looking clean ECGs. When you try and record ECG using your Apple phone, sometimes you get this noisy wandering baseline, so that our models just don't quite work. And we're doing some work at the moment by injecting noise intentionally into the model, so the AI is used to seeing all the wearable signatures of noise, so it can learn to neglect those and focus on the actual signal itself. And this exercise, we did the same approach with training models, but we added noise from wearables. So it's able to look at noisy signals and still make the diagnosis. And what we found was that actually injecting real world noise seems to have a marginal benefit of improving the performance of these models. So how do we see this applied, and how can we see this applied in hospitals across the UK? One vision is to have all ECGs that are recorded anywhere in the UK be put through some of these AI models to output predictions for the physicians. So I've got a video here to show you how this might work. Will this play? Apologies. There we go. So you have a model here, you can put the ECG on there, and this is real time. So the models, when they're trained, they can analyze ECGs very quickly. So once you put the ECG in, it takes about 5 seconds, and you can output a prediction of whether someone currently has any structural heart disease with a degree of confidence. It'll give you a 5-year prediction of future problems based on a single ECG and how you fit in with the rest of the population. It might even then tell the physician what it's looking at, which bit of the signal is important, and why it's making some of the classifications and predictions that it's doing. So it gives the physician a bit of some ownership of the predictions, and the physician then can take it or leave it. They can use these predictions to make their decisions in clinic. So that's what we've got to with the research. We're very excited by it, and I think it's got real utility going forward. I'd like to finish with 2 slides that I always finish off with when I talk about AI. One is this editorial, which was written to accompany an AI ECG paper. And in it, the editors refer to trusting magic, and that's the title of the editorial. And they quote Sir Arthur C. Clarke, who said that any sufficiently advanced technology is indistinguishable from magic. And at the moment, some of these things that I described may feel like magic to clinicians. Take an ECG, predict future heart disease. Take an ECG, predict undiagnosed heart failure. But that's where we're at the moment. And the challenge for physicians, and I guess for patients and everyone else, is whether we embrace this slightly magical technology of AI and how much of it we're happy to use in our day-to-day practice. The second slide I finish off with is this. People ask me whether AI will replace humans and cardiologists. And my answer is no, AI will not replace humans, but humans who embrace AI will replace humans who don't. So AI is here to stay, and I think we all need to embrace it. I want to finish off by acknowledging the team. It's really the work of the team here at Imperial College. It's a very international, very multi-talented team who've done all the work here, and they deserve all the credit. Thank you very much.
Thank you so much, Siong. That was really inspiring and extraordinary, the information you can get. So can I thank both speakers, Madhu and Siong, for their really insightful and helpful presentations on current and the future of cardiology, nationally and in Cumbria. I'm really grateful for the time you've taken.